Welcome to this session on addressing difficult topics in aging and disease. My name is Tony Denuzzo, and I'm director of the East Texas Geriatric Education Center. And I'd like to acknowledge our partnership with Texas AHEC East that have been very valuable in helping us disseminate our information to the different parts of East Texas and our service area. Today we will be having our fourth session looking at modeling long-term care, the health of older prisoners, and nursing home residents. And as you'll see, the mission of the East Texas Geriatric Education Center is really to enhance interprofessional geriatric education training across the entire curriculum throughout the different groups of students, residents, fellows, and really in healthcare providers in all disciplines. We do focus a lot on medicine, nursing, social work, occupational therapy, physical therapy, and physician assistant studies, but we try to include all health professions. We became a consortium in 2010. This GEC has been active since 2003 as a single entity, and we expanded to a consortium in 2010. And we have several consortium partners throughout UTMB and the East Texas area. And you will see that they are here with us through video conferencing and to our different sites. We have a lot of programs that we do, and I think it's good to just review these for just a minute. We do a lot more than this topic series, although this is very much a highlight of what we do. We do a faculty development program in geriatrics. We have an active group with the geriatric fellows, as well as in physical therapy right now. We'll be expanding that to nursing next year and to social work. And we do a lot of education in our ACE unit with improving communication skills and enhanced training in clinical work. And that is headed by Branya Mishniko, who is the coordinator of the education program in the ACE unit. We try to do as many workshops as possible throughout our service area and sponsor several during our budget year. And we also do programs that target special groups, older prisoners, rural, elderly, and older minorities. And we will be covering the older prisoner group this afternoon, as well as nursing home residents. Okay. Finally, a big thing we do is provide lots of continuing education credits. That's a valuable thing for all these disciplines, and we're happy to be able to provide these free of charge. Okay, all our programming is free, and we really welcome any suggestions on what we can improve on and expand. In fact, that is the budget. We just received word that our funding has been awarded for another year beginning in July. Yay! And we hope to expand much of this into other parts of East Texas. All right, so this series began in January, looking at difficult topics in aging. This is the fourth one and the last of the series. And just so for your information, we have box sets of what we did last year on healthcare reform, a four DVD set. And there goes one of them. And we have a few complimentary copies, if you'd like, outside on the table that you can take with you. We will have this series of four set in a similar kind of box next year. In fact, I just received the one on cancer that we did in April. All right. So that'll be available free of charge if you'd like that for your own resource and to provide that to your colleagues. Okay, so we will be doing this session looking at the challenges, ethical issues regarding health of older prisoners and nursing home residents. Our first speaker will be Patrice Barnum, Dr. Patrice Barnum. We have a little short bio on her. We'll have a short break, and then we'll have Dr. Meredith Massell talk about advances and challenges in nursing home care. Also, we have webinar access for this, and we will provide CE credits for those who contact us through the webinar. These are the objectives. We have handouts. They should be in your handout. I won't go through these, but these are the learning objectives for this session. Okay. And And these are our teleconferencing sites over in Lamar University in Beaumont, Stephen F. Austin in Nacogdoches, Baylor University in Waco, Victoria College in Victoria, and Weatherford College in Decatur. CE credits we are offering for continuing for medicine, CME. This session is good for 2.5 Category 1 credits. And there's a sign-in sheet for this, attendance and evaluation forms you will need to fill out, and we will get you the certificate as soon as we can, within 6 weeks, hopefully. Our disclosure is that none of our speakers or those in our planning committee have any relevant commercial financial interests or affiliations to disclose. Okay. We will offer CE credits for social work, point 3. For this, there's a sign-in sheet, fill in a registration form and an evaluation form, and you will get your certificate for social work. Okay. Nursing for C&E credits, we have nurses and LVNs. This is good for 2.75 nursing credits. And again, our same disclosure. None of our speakers or committee members have commercial financial interests or affiliations to disclose. And there's paperwork out there, and there are people around that could help you fill that out if you want to get your C&E credits. And LVNs will receive a certificate of attendance stating the topic and the hours of attendance for that. This is the final disclosure also for C&E that is required for successful completion of the program. No conflicts of interest, relevant financial relationships, commercial support, endorsements, or off-label use that will be discussed. Okay. C for physical therapists and occupational therapists will also be awarded, and there's a letter that goes with this of credit, and mostly it's the evaluation form that we need for that. All right, any questions on CE or anything else about the GEC? Okay, I'd like to introduce our first speaker, Dr. Patrice Barnum. He's going to be talking about the older prisoner, ethical challenges to providing health care. I think this is really unique in terms of us providing this through the GEC. This is one of our target groups that we feel we really don't know much about, and I really am pleased to have Dr. Barnum talk to us about that. This is her bio. It is in, I won't take too much time to read it. It's in your handout. And please welcome Dr. Barnum.
Thank you very much, Tony. Thank all of you for coming. I am currently a physician at the Carroll Young Medical Facility in Texas City, and I will be speaking about the older prisoner, as Tony alluded to earlier. In looking at our topic for this series, which is difficult topics in aging, I personally can't think of any topic more difficult to talk about than the prisoner. A lot of people don't want to hear about prisoners, but I think it's something that's very important, and I'm very grateful for this opportunity. And I hope that all of you leave here having learned something about the older prisoner, but also I hope to leave you with something to think about once you do leave here. So my objectives for today are to provide a general overview of the healthcare in our prison system with specific details about correctional care in Texas. To describe our aging population with emphasis on the older prisoner and the geriatric services that have evolved as a result. To identify barriers and clinical challenges to providing health care to the correctional population, and also to briefly discuss some ethical issues in providing health care to the prison population and potential solutions to address this aging trend. And also, throughout my presentation, I'm going to have some questions about common prison terms. And so when you leave here, your prison IQ may be a little bit higher, but I would like for you guys to participate with that. So we will start off with the clinical case that I'm going to present now, but we will discuss at the end. We have a 63-year-old male, DW, who presents for intake to a TDCJ unit in June of 2005. At that time, he has no acute complaints. He denies any difficulty with walking or any other activities of daily living. Past medical history, after some research, reveals a history of diabetes, hypertension, and osteoarthritis, and he cannot give us a length of time of those diagnoses. He's divorced, he has no children, and he's living with a friend. He does report some alcohol use. For many years, states that he drinks beer and wine. And when asked about his medication, he states that he cannot remember any of his medications. His physical exam is remarkable for a blood pressure of 168/92. His weight is 180 pounds. He's 5 feet 10 inches tall. He has poor dentition with many missing teeth. And I've noted that during the physical exam, he's coughed several times. And although he said he didn't have any issues, he appears to have an unsteady gait. Not surprising, after this intake process, he's sent to a small unit, likely because of his age, versus going to a very large facility in general population. About 4 months after intake, some of the other inmates report that he has not been going to the pill window, he's not been eating, and he's been urinating on himself. So he is sent to the medical area of the facility, and he's seen by the PCP there, and it's decided to send him to an infirmary. And in the infirmaries, basically there is increased nursing care. Most of them, all the infirmaries have 24-hour nursing care, and they have staff to assist him with his activities of ADLs. So he's sent to the infirmary. His MMSE is 21 at that time, so he's diagnosed with mild cognitive impairment. He receives a walker from the physical therapist at that facility. 6 weeks after admission to the infirmary, he develops a fever with cough and is admitted to the hospital. During his 8-day admission in the hospital, he's treated for pneumonia, and then he's discharged back to the infirmary with instructions to continue physical therapy in addition to all his other medications. Shortly after arrival to the infirmary, he has to be confined to his room by security, which is what we call safekeeping, due to the fact that he was wandering, and he wandered into another offender's room and used his toothbrush. And often we place our patients in safekeeping to prevent other offenders from hurting them. In this case, because of his cognitive impairment and his wandering, it's best to confine him to a room. Of course, he gets out for showers and those things, but most of the time he's confined to his room. So in March 2007, he's seen by the PCP for routine follow-up. Evaluation done, his MMSE is now 14. Despite evaluation by speech pathology and alteration of his diet, he has lost 12 pounds, and the nursing staff reports he continues to choke with eating. So over the next several months, he continues to decline with advancing dementia. He's now non-ambulatory, and he has very poor oral intake. The staff is very concerned about this patient. They're concerned about him aspirating, and his weight has now plummeted to 140 pounds. His nurse inquires about PEG tube placement, and multiple attempts to contact family have been futile. We've not been able to contact any family. So I want you to, I know it's a lot of information, but if you can kind of keep this case in mind as we go through the presentation. Correctional care in Texas. The Texas Department of Criminal Justice operates one of the largest correctional systems in the world. I believe only California and the Federal Bureau of Prisons has a larger system. 2 historic landmark cases determined how incarcerated individuals would be treated and receive medical care. Those 2 cases, many cases actually occurred to get us to where we are today. But Estelle versus Gamble and Ruiz versus the state of Texas are 2 cases that come to mind and were very important. The constitutional right of incarcerated offenders to receive medical care was established by Estelle versus Gamble. And the U.S. Supreme Court ruled that deliberate indifference to serious medical needs was a form of cruel and unusual punishment that was in violation of the 8th Amendment. Ruiz versus the state of Texas directly affected how care to prisoners was provided in our state. Gamble was in 1976, and Ruiz versus the state of Texas began in 1972. As a result of these cases and others, it was determined that government had an obligation to provide medical care to those who was incarcerating. And as a result, 3 basic rights of prisoners was established. They have a right to access to medical care. They have a right to access emergency care, routine care, and they have a right to access that in a timely manner. They have a right to be seen in the hospital. They have a right to be seen by a specialist, basically the same as we have. They have a right to care that is ordered. So if a provider in the correctional system orders something, then we must provide that care to those who are incarcerated. We cannot deny them that. We have to make every effort to provide that care to them. And lastly, they have a right to professional medical judgment, meaning that they have a right to receive care from qualified medical personnel. So here's my first question. What is the chow hall? Who said it first? Okay, here you go. Okay. Inmate dining room or area. And I'm sorry about those off-site. If I could send candy there, I would. Okay, so what is correctional managed care? When I first joined correctional managed care, I was confused on exactly what it was. So let me try to explain. It is a strategic partnership between the Texas Department of Criminal Justice, UTMB, and Texas Tech. And CMC, Correctional Managed Care, is a division of UTMB that basically runs the day-to-day operations in providing medical care to prisoners in the state of Texas. We are focused upon a shared mission, and that is to develop a statewide healthcare network that provides offenders with timely access to a constitutional level of health care while also controlling the costs of this health care, which continues to rise. And it is managed by a statutorily established body, which is the Correctional Managed Healthcare Committee, which consists of 9 members appointed by the governor, and 4 of the members are physicians. Here we can see the state of Texas. The area that's in white is the area where UTMB provides the health care, and the area that's in light blue is the area where Texas Tech provides health care to the inmates. And UTMB has roughly 121,000 inmates it provides health care to, while Texas Tech is about 32,000. So UTMB provides 80%, where Texas Tech provides about 20%. And some of the services we provide, we have 86 state prison medical facilities. We have 2 inpatient psychiatric facilities, each with 500 beds. We have specialty clinic operations that occur here at Hospital Galveston, but we also have some that occur at the units. We have 471 infirmary beds, 2 dialysis centers, a 200-bed women's sheltered housing facility, and we have a dedicated geriatric center with 60 beds, but we also have geriatric beds in other facilities as well. But which I'll speak of later, the Type 2 facility has 60 beds. As I stated, we're responsible for the health care of about 121,000 offenders. We also have ambulatory services on all the facilities. We have facilities for offenders with cognitive impairment. We have 2 inpatient hospice units. The male hospice unit is Estelle, and the female hospice unit is the unit I work at, which is Carol Young. We have 12 units with wheelchair beds. We have system-wide pharmacy services, specialty and inpatient services here at Hospital Galveston, and we have telemedicine services. We see about, if I'm not mistaken, about 30,000 consultations a year with telemedicine. What is a shank? There we go. Handmade prison weapon, generally a stabbing instrument, and they'll make it out of anything anything pretty much you can think of, anything that they can get their hands on. So in 1990, the Texas prison population was less than 50,000, and today we have roughly 150,000 inmates. So we can see this tremendous growth in the past 2 decades. But with this growth, with this increase in the prison population, we're also seeing a lot of demographic changes in the health of these prisoners. We see higher rates of infectious disease. We see mental disorders. We see lots of end-stage liver disease, lots of end-stage renal disease, hepatitis C, HIV. All these disease processes are increasing in number, and the treatment of such is, not surprising, more complex and costly. And we're also seeing an increasing percentage of elderly and female offenders, which usually require more of the health care costs. So this is to show you basically a breakdown of our inmates in regards to age and gender. So we can see that offenders less than 50, roughly 84%. So they still make up the vast majority of the inmate population. Patients basically 50 and over make up about 16%, 50 to 54 about 8%, and 55 and older about 8%. And as you can see, the female population is considerably smaller than the male population. Inmates age 50 and older, if we look at from 2004 to now, there is a very gradual and steady, I don't know if you can even call it so gradual, but there is clearly a steady increase in the numbers of inmates 50 and older. 63% increase between 2004 and 2012 projected. So with this increase, we can expect to see more of the geriatric giants like delirium and dementia and incontinence and falls, because this population continues to increase in numbers. So the offender population is growing grayer as it grows larger and it grows sicker. Justice Department statistics show that the number of inmates in federal and state prisons age 55 and older increased by 33% from 2000 to 2005. If you look at basically from, and I wish I had a graph for this, but if you can kind of visualize this, from 1997 to roughly about 2006, 2007, so a 10-year span, the number of offenders went from about 130,000 to 150,000. But if you look at inmates that are 55 and older, that doubled. That went from 8,000 to 16,000. So you're seeing a dramatic increase in those offenders that are 50 and older. And in the southern states, the growth rate was 145% versus the whole nation being 33%. So in the southern states, you're seeing a more dramatic increase. That's felt to be from harder sentencing, basically. Next question, what is GP? Does anybody know what GP stands for, I guess? Okay. Yes. Let's see, I'm not the best. Yes. Oh, thank you, Dr. Raji. Yes. GP stands for general population. Okay. So here we get to the older prisoner. There's no absolute cutoff, but most states use 55 and older. Some use 50. But just as the population in the entire world is increasing, we see that the older prisoner is mirroring the national trend. We're seeing increasing numbers, people are living longer, and then with that is coming all the comorbidities, hypertension, diabetes, coronary artery disease, all those things. One of the important factors in this is that, as in the free world, the older prisoner uses a disproportionate amount of healthcare resources. They are 3 times more likely to have on-site medical care. They are 6 times more likely to require hospital admission. And so even though they make up, if you take 55 and older, even though they make up that 8%, they're using about 30% of the cost. And if you look at the cost of a hospital admission, it's significantly higher in the older prisoner versus a younger. So when you are tasked with taking care of an older offender, it's helpful, it's useful to know, what type of offender you're dealing with. If you can possibly know the history. Is this their first incarceration? Were they incarcerated at the age of 30 and then they've been aging in prison, or are they in and out? So in the literature, you see described a subset of older prisoners. You have first offenders who are first incarcerated at age less than 55, but that can be 50, that can be 52. So you may not know what kind of medical care they have been getting prior. And then you have the old offenders who were first incarcerated over the age of 55. And so those patients have basically received most of their care outside of prison. And then you have the old timers who are aging in prison. Those are the ones that were incarcerated at a very young age and have spent their whole aging process in prison. And then you have the recidivists who are in and out, in and out, in and out. So you really don't know, they come in, they may get, excellent care for a period of time, and then they go back out, and they may have gotten no care, may have gotten care, but you really don't know. So why are we seeing an increase in the older prisoner population? You have to ask yourself that question. Stacking effect. What we're seeing with that is you're having the same amount of individuals incarcerated yearly, but you're releasing fewer, so your numbers are increasing for that reason, because you're releasing fewer prisoners every year. Then we've seen over time that there are longer sentences and mandatory minimum sentencing laws. With the second and third strike laws, the 3 strike laws in particular are statutes enacted by state governments in the United States which require the states to impose a life sentence on those individuals that commit serious offenses for the 3rd time. So if usually it's murder or rape or aggravated burglary, those types of serious offenses, you commit that 3rd felony, then the states are pretty much required to give you a very lengthy sentence. Usually it's life. It can be with the possibility of parole, but it's a really long sentence. We're also seeing less judicial discretion in that there's no gray, it's all black and white. So if they do this crime, kind of along with the 3rd strike laws, then you have to serve this amount of time, and there's not much exception to the rule, and this is the sentence that they're going to get. And then of course you have the repeat offenders. Texas, I believe, was one of the first states to enact the 3 strike laws, and I believe that was in 1974. What is commissary? Raise your hand. Store, okay. Yes, it's the store inside the prison where the offenders can purchase food or personal items with the trust fund account. Lucy, okay, here you go. Whoops, okay. Yes, so the offenders can purchase many different items, personal items, as they stated, soap, shampoo, those sorts of things. Food, of course, it's non-perishable items in general. Sometimes there's ice cream and those sorts of things that they can get, but they have to eat that really quickly because they have no place to store them. So if they have money put into their account, they're able to purchase these things. In the literature, you often see the term of accelerated aging used, particularly when you're talking about prisoners. And often, when I see my patients, they look a lot older than what they really are. But accelerated aging is defined as a physiologic age of the patient that is about 7 to 10 years older than what their actual age is. And so with that, you're seeing a patient with diseases or disease processes that you might expect to see in a patient 10 years older. But you know, you're seeing it in a guy that's 40, for instance. So you have to think about that when you're treating these patients, that their bodies in general may be older than what their actual age is. And when we look at the causes of that, not surprising, a lot of our patients have had inadequate health care prior to incarceration for various reasons. Lifestyle, substance abuse, stress, of course, depression that we may be seeing. The stress of incarceration is another thing that we have to consider with this accelerated aging. And those patients that are in maximum security facilities, of course, deal with more stress than those that are in minimum security facilities. So, you know, when we talk about the geriatric patient, we always talk about ADLs. Well, there are ADLs that are unique to our prison population. Dr. Bree Williams spoke about this when she gave her lecture with the Winter Series about, we sometimes term it paddles. But some of those activities are walking to the chow hall, pill window, and showers. I mean, that's how medications are given on the units where patients are ambulatory. They have to walk to the pill window to get their medications. They have to walk to the dining area. They have to walk to their showers. Don't see too often, but they have to be able to drop to the floor if necessary. I mean, many of the facilities have bunk beds, so they have to be able to climb onto bunk beds, climb stairs. Hear and understand verbal orders from security. That's very important. You can get, our patients can get cases, they can get in trouble essentially from not following orders that are given by security. And you can imagine if someone's hard of hearing, it's not, you know, they're not being defiant, they just can't hear. If they have dementia, it's very difficult. They have to be able to communicate their medical and security needs in writing at times. At our infirmaries where we have 24-hour nursing care, there's always someone having an eye on our patients. But if you're at a regular unit, you're in general population. That's how they communicate majority of the time that they need something. They'll write to medical, they'll write to security if they needed a certain item. And they have to be able to squat and bend for searches as well. Housing for our older prisoners. In addition to just general population, and if our patients are functional, if they're ambulatory, no dementia, they can be housed in general population. And most of them are okay with that. But a lot of our older prisoners are not able to be housed in general population for various physical or mental health reasons. So we have type 1 and type 2 geriatric facilities. And when I'm taking care of patients, we decide, okay, is a patient appropriate for a type 1 or type 2? And the main differences between, actually the next slide will give a little bit more detail, but there are some differences between type 1 and type 2 kind of being more sheltered. And then we have, you'll hear me use the term infirmary, I have been using it. And then we also say inpatient, which to me is confusing because a lot of times when I say inpatient, I think of a hospital. But when we say inpatient, we're talking about infirmary care. And infirmaries are facilities that are single level and there's 24-hour nursing care. And patients are classified as assisted living, and those are basically our ambulatory patients, but they just need some assistance with some ADLs. Our convalescent care patients are generally our patients that are bedridden, non-ambulatory, our demented patients, patients requiring more care. And then we also sometimes place patients in hospice. As I said, we have the male and female hospice units. And there are pros and cons to special housing and integration. Some of the pros, I guess, would be that, you know, by separating them from the younger population, they're not preyed upon, the environment is quieter, the environment is calmer, they can relate to people their age. A lot of them sometimes feel more secure in being in their own separate environment. But then I have some elderly patients who prefer to be out with the younger population. They prefer to be, it makes them feel more alive. It makes them feel more energetic being with younger guys. And they ask me to go back to facilities where they can mingle with younger people. And I've also seen where there is almost like a surrogate relationship. You might have an older offender with some mild or moderate dementia, and a younger offender is taking care of him, is helping him, and they become attached and they kind of form this relationship, you know, kind of helping each other out that's really beneficial for both of them. So there are pros and cons. And I'll actually, see how we're doing on time. I'll take this time to go ahead and I'm going to show a hospice video. It's Angola prison in Louisiana, but it gives you a look inside the hospice there. And that is, you know, similar to the same care that we provide, and the concepts are the same. So.
Dad, oh man, it's been very touching. You know, it didn't brought tears from my eyes because by working here, you get close. You know, you gain a relationship with the guys, you know, and it really hurts you. And just being there for them, you know, it takes a lot out of you, but it puts a lot in you.
Did a lot of wrong, and I hurt a lot of people out there. And when I heard about hospice, it was in my heart to join because I say this would be my way of giving back to society. Can't tell those people that I'm sorry for what I did. You know, the ones that's living, you know, they wouldn't want to hear it. So instead of me talking about it, I'd rather do something about it. This is my way of doing something about it.
Who would have thought that Claude would be taking care of somebody? I mean, it's nothing for me to go in, if a guy is sick, to bathe him or to change his diaper if necessary. That don't mean nothing. But years ago, man, I would have never thought of that. And guys that know me know this.
When I came here to be the warden, it didn't take long to realize it, and realize that 85% of the inmates were going to die here, and you have to think about, well, what about the inmates who are in here who are suffering, and how do they die? And they go off to the hospital, and nobody really with them, no family with them, because by the time you've been here 25 or 30 years, most of your family's dead or gone. And then hospice came to mind. Why don't we have a hospice program? And I read something about hospice in the Baton Rouge paper. And so the idea just took off.
Very first time someone said to me, Warden Kane wants a hospice program in Angola. He says he wants it and it's going to happen, so we're going to get it done. So I think at first there was a little resistance, and it was not like we don't want this, but we were mindful of where we are and who we take care of and why they're here. The principles, the main principle of prison hospice is the same as it is in hospice in the community, and that's to provide comfort and caring to a patient in the last days of terminal illness. So that's no different. There are different components of hospice, and also there are different components of a prison hospice. So what we do is we take the community hospice and then we add those components that are necessary in a prison setting. So we have nursing, physician services, we have pastoral care and bereavement, we have volunteer services, we have social work services, and specific to prison we have classification and security.
When we began the program, we were in two separate places. The prison knew a lot about correctional issues, and we knew a lot about hospice, but we didn't have an integrated knowledge base, and that was one of the first challenges. We needed to learn each other.
Hospice is a team concept, and in the free world we don't have anybody on the team who's security, and in the prison you have to have somebody from security because they're involved in everything that goes on there. And we thought if we're going to be effective in doing prison hospice that we really need to understand that component of it.
As far as my security staff at the treatment center, at first it was hard for them too, because most of these people, hadn't been in Angola but maybe 1 or 2 years. And they go through the academy and they show them how to be a hard nose. And, if an inmate is messing up, write them up and lock them up. And when you get a program coming along like this where you got to care for somebody or actually try to do a little extra for somebody, and they look at me and say, why do we have to do all this extra stuff for this inmate? And that's when we first started getting to the program. And now it's real easy for them. I guess it's a different thing when you see somebody dying on their last leg there,
The interdisciplinary team is a team of hospice professionals. It includes the doctor, the nurse, social worker, classification, security, pastoral care, and any other staff member that has some involvement with hospice and or is interested in providing hospice care. During the IDT, we also formally admit patients. Prior to the admission process, each discipline pulls together their own assessments, so we're able to discuss what our findings are and formulate a plan of care.
Greg, we're going to just do IDT just on Danny today for time. And Richard, do you want to start the psychosocial?
There were 3 occasions where I attempted to gather psychosocial information on him. On all 3 occasions, either he was asleep or he was not lucid or clear enough to provide information. So this basically comes from Tanya's interactions with the patient and the patient's family. He's currently diagnosed with lung cancer with metastasis to the brain, and he was diagnosed on 5 of 98.
We expected he was going to sail down here about 2 days ago, and he didn't, but I don't think he's going to make it any longer than a week.
Has the family given any indication about how to handle his body at the time of death? Because he has not wanted to talk about that with me.
I think they're probably 98% sure that they want him to be buried here. They're not financially able at this point to absorb the cost.
Some people might get mighty tired if we run a vigil through 3 or 4 or 5 days.
As far as volunteers?
Mm-hmm. You can switch the volunteers around, I expect.
Don't worry about that, because during vigil, security does allow them to be released from their jobs when they're on vigil.
The administration went to certain inmate leaders, explained the program to them, and asked them to suggest members for this first group. The idea behind that was that this program is for the inmate population, and they, better than anyone else, can guard the integrity of the program. They need this program. They know they need it, and they have a personal investment in making it work.
We were doing this type of work, we just didn't know they had a name for it. Idea came about, well, let's do a hospice program. Well, what is hospice? Oh, coming to the hospital. I said, oh, we already doing that, So we pretty much with the first group of guys almost handpicked the guys because we knew all the guys who were already doing this and just went around and asked them, look, we're trying to start a program to do what you're doing now. The guy said, what's that? Visiting a patient in the hospital, sign me up.
In our death awareness training, some of the questions we ask are, what was your first experience of death? And I asked that question, and I told them to think about it, and very shortly after that, one of the inmates raised his hand and he said, Well, he said, I have to tell you, he said, for some of us, our first experience with death was with the person that we murdered. We didn't avoid that in any way. It's not like we modified it, but it just gave us a different awareness, and it gave the training a different feeling.
So we need to be always mindful of the fact that these people deserve our respect. And that's all I've seen out of any of them.
The inmates absolutely embrace this program, and it's changed how they think about going to the hospital. It's changed how they think about dying in prison. It's had a profound impact all the way around.
The hospice philosophy was to make you more comfortable, you know. You're already uncomfortable in prison. You're uncomfortable with the number of years you've been down and the separation from your family, to where the people in Angola, the other inmates, become your family after, I've been down 19 years. You know, after 19, 20 years, this is more or less who your family is, you know, your closest family. You become closer to prisoners in here than you do to your own brothers and sisters in the streets, you know.
One of the things that is important to hospice is when someone dies that we have a bereavement program in place, not only for the family who lost them, whether it's their biological family or their inmate family, but for the volunteers who sit with them.
We're going to try to look upon the mystery of life and death as our brothers experienced it and as we experienced it with them, as a reaching out for the light.
I remember the first day at the hospital over there, I was, you know, and I just told him. He didn't say anything. We just started talking about death and life, you know, and I explained a lot of things to him. I'm not quite sure what all I said, but I know there was something that happened between us. It kind of, I can't explain it. I walked in one time to come see him, and I reached over to shake his hand, and Dre just pulled my hand to him, kissed it. He woke up, and he made signs. I thought he wanted me to massage his back. And so I picked him up by his neck and pulled him up so I could reach his back. And he whispered in my ear, that he wanted me to hug him. While I was hugging him, he told me he loved me. Last thing I heard him say.
This program has opened some doors for men to recognize the value of friendship in a healthy manner. The program has clearly developed an experience of family among the men incarcerated here that is something I have always known as crucial if a real humanizing of this environment is to take place. These things have already happened at a very small level as a result of hospice.
Presently there's a man who's on vigil at Angola whose family has come. One thing that hospice tries to do is to treat not just the person who's ill but their family as well, and we consider them a unit of care. We don't consider them as we just take care of the patient or we just take care of the family. We take care of everybody. Whatever their emotional, spiritual needs are, we try to minister to that as well.
Put it on the back of his head, on right here on the neck, put it on his neck, it stops the non on his neck. And put some cold towels. I was really surprised when we got here, and there was a guy from hospice sitting in there, and it was a lot of relief to know that he wasn't by himself. I mean, it's not family, but it's somebody there at a time when he needs somebody. My heart was heavy, very heavy, because I had the need to see my brother, to let him know I forgive him, and that it's okay, you know, he's forgiven and he can go home in peace. And this hospice has given that to him. These guys that sit here lovingly with him and pray with him and just sit. Some of them just sit hours on the side of his bed not saying a word if he doesn't want to talk, just to let him know that there's someone there.
And in a way, this hospice program has let me see from these families coming up in here how they're crying and how they're hurting over seeing their loved one in a position like that, that I put people in positions like that and in places like Patients Inn. It's not nice, you know. I have a mother, I have a family, and I wouldn't want nobody to do me, you know, what I did to other people, to have my family grieving over me like I see these families grieving over patients in here. So the hospice program has enabled me to let go of a lot of anger, animosity, and hate, you know. I was a little racist even before I got into the program. You know, even coming to prison, I don't hate, you know, it was, for me, coming from a rough neighborhood, it's always a white and a black thing. You know, because the judge gave me my time, the DA was white, the lawyer, so evidently you build barriers up. The hospice program helped me tear that down, because I can honestly say I love my patient, and he white.
For us, the inmate volunteer corps is essential. And we talked about, do we want to allow volunteers from the outside to come in, and the decision was made that we did not, and we felt like that increased the security risk to bring in people from the outside. So I think that any institution that would feel like that they could not incorporate volunteers into their program, I would hope that they would look at that very carefully, because they're a great asset.
Dealing with another inmate is just something about, you know what I'm saying? I might not tell you as a doctor, I might tell them, you know, because I feel more comfortable with them because I done lived around them. So if you never been in a situation, you never been in jail, how could you tell me about jail? You never been there. You know, how could you tell me how I feel and you never been locked up? You know, even though he might be dying, I know that I'm here. I have enough time where I may have to die here. So all this running through my head as an inmate. And so I want to be there for him because I feel the pain that he feels.
The hospice program came along at a time when we ran out of space at Point Lookout 1. They made space for a new cemetery that can accommodate 2,000 people. Well, we knew right then that we had a problem, that they were making preparations for people to die here. The laws being as they are, life meaning life in Louisiana, guys are staying here so long till they're dying here. So I think hospice came along at a time to, I guess, accommodate it. You know, that if the guys are going to die in prison, let's try to make that transition that much easier.
Let me get that for you, Mr. Lamont. My legs are better than yours.
This hasn't always been like this. At one time, we'd come out here, drop a guy in the hole, and go on. Now, as you can see, we're set up to have a full-blown funeral with all the respect and dignity that the guy's supposed to have, okay, you know, in death. And the hospice program, once it started and everybody focused in on prisoners dying, we focused on this too. As I chose, I didn't want any operations. And I'm sure other people will feel the same way. I don't want to be butchered up by doctors experimenting with my body, you know, to see if they can do anything with my liver. They can't guarantee me a cure, and they can't even give me any good percentages that they can even help me or give me any quality of life. The most that I've been told that my quality of life could be through hospice, you know, that they're going to help preserve my dignity and ease my suffering, you know.
When you go through nursing school, you're taught to save lives. And your first concept is to do everything that you've learned, everything that you can conceive to save that person's life. Well, in hospice, they've elected to just let their disease take their course and to accept death. And you, as a nurse, have to accept the fact that this is what they want. And you can't do any heroics. or anything like that to try and make it better for them. In some cases, you're making it worse because you're prolonging their agony. This is a concept you have to accept in hospice.
I was told before we started that the security would be prohibitive, but the security has not been a problem. I was told to be careful, that the inmates were manipulative and would only do things if they thought there was something in it for them. And that has proved to be untrue. Not only proved to me, but proved to the prison administration to be untrue. On a more practical side of it, you can save a lot of money with this program. And that is a concern, a practical and a legitimate concern. It doesn't make any sense to spend money on treatments that are not going to be effective. And this whole country, as well as the prison system, is going to have to come to grips with that.
In the hospice program, we are dealing with men who are coming to the end of their sentence. And I don't care how long their sentence was, even if it was life. That individual may have done some really awful things in life and impacted the lives of others in a very destructive manner through that. We recognize that. And if we're going to prepare those who are coming to the end of their sentence to be constructive citizens, then I think we also have an obligation to prepare those who are coming to the end of their sentence through death. And just as importantly, for preparing those who have been touched in some way by the life of that person for being at peace with the death of that person. And my hope would be that society can see what we're doing in hospice in no way as a coddling of men who have committed crimes, but simply as a way of preparing some human being who is coming to the end of their sentence for doing so in a way that is peaceful and open to something constructive.
Well, I feel as though now if I never get out, if something happened to me before I get out in here, that I won't have to be alone. When that day comes, I don't feel as though I'll be frightened of it. This program is going to go higher because you got guys in it that's sincere. You got guys in it that, you know, we used to think about ourselves and the heck with anybody else, you know. And I've seen the guys that used to run around Angola and want to fight and jug up, actually cry and be heartbroken over the patient. And this program, it's going to go higher. It can't help but go higher. You got some dedicated people behind it. No longer bound, no chains holding me, my soul resting, it's just a blessing. Praise the Lord, hallelujah, I'm free. Praise the Lord.
Going back to housing, so you were able to kind of at least get an idea of a prison hospice, although that was not a Texas prison hospice. Let's go back up to the differences between type 1 and type 2 geriatric facilities, or what they basically offer. So both offer basically we designate for patients that are 60 years of age and older, but we do make exceptions to the rule. If they're 55 and we feel like it's a good fit, we would certainly try to accommodate them. It is a dormitory setting. In order for an older prisoner to go to a geriatric facility versus an infirmary, they have to be independent in their ADLs. If they can't do their ADLs, then they need to go to an infirmary setting where they can get more assistance. The advantage is the distance to medical area, to the child hall, to the showers, to the pill window too is shorter. And all the geriatric facilities in our units are single level, so they don't have to climb stairs. And the type 2 geriatric facility is environmentally controlled, air conditioned, because the prison units are not air conditioned. And I'll show pictures, their meds are taken to them and their food is in the same area. So that's the basic differences. Anybody know what rack time is, or rack in?
Their bed in their cell?
Close. I'll give it, when they're all required to return to the cell or dorm area. Want me to try, or give it to Dr. Raji? Okay. Thank you, Dr. Raji. Been great. You've been great. Okay. No movement is allowed during that time. And usually we say rack them up so that we can count, because there's count time several times a day in the prison. Okay, so this is a picture of the type 2 geriatric facility at Estelle, actually. And here's the dining area. And I just like to point out that, there's space in between the tables. It's quite spacious. The lighting's pretty good. But if you see in the back, that's actually where they sleep. And that's the nice thing about that facility, which is the only one, is that everything is in one area. So they really don't have far to walk at all. Because any other unit, you're going to be walking to get to wherever you need to go. So it's very nice and unique, and it's air conditioned. And then this is in this same building. This is where the meals would be served. And when I was preparing the presentation, I asked myself, well, kind of what's the advantage of that versus having the meals taken to them? But, daily prison life is pretty monotonous, and there's not a whole lot to do. So even getting up out of your bed and walking through the food line to get food is an activity. It's something that they can feel independent about, something that they can do, believe it or not, other than just be in bed. So that's that area. And then this is the housing quarters, I guess, dormitory setting, a bunk basically. This is in the geriatric facility, but this is similar also to a lot of our sheltered housing units and a lot of our other dorms at many other units, where you basically have the bed there. You can see it's pretty low to the floor. There's a lock box under the bed, and they can lock their belongings there. You can see the doorway's pretty wide for wheelchairs. They have a wheelchair and they need to get in and out. And you can see a lot of personal belongings there. But that just kind of gives you an idea of the area they sleep in. They usually allow one blanket, one pillow, those sorts of things. And then this is what our infirmary rooms look like. There's anywhere from 1 to 4 patients in an infirmary room, and they all pretty much look the same. A lot of the units are near exact duplicates, especially when it comes to the infirmary, Estelle and Carol Young. And you can see it's pretty much a hospital bed, probably a much older version than what we have here at John Sealy. But they do have the tray, bedside tray, and some of them have their meals served to them. But the ones that can walk, even in the infirmary setting, they have to go and get their meals. We encourage as much mobility. The same geriatric principles apply. We encourage mobility, independence. If you can do it, you need to do it yourself. And then, like, if we need oxygen, suction, all those sorts of things, the rooms have all those capabilities as well. And then this is a typical unit. So can you imagine a geriatric patient trying to get up and down those stairs, you know, and so, I mean, it just, you know, it just wouldn't work. So most of them, it's nice to have these geriatric accommodations for our patients. And I just wanted to point out, because, you know, there are a lot of things that apply to the free world that don't apply to the prisoner, where, well, the American with Disabilities Act and the Age Employment Discrimination Act require prisons to make reasonable accommodations for individuals with functional limitations. And a functional limitation is defined as a physical impairment not expected to improve within 6 months that impairs a major life activity, including their ADLs. And so employment, transportation, activities, programs, all the services must be equally accessible to those who are disabled, you know, including age-related disabilities. So because our patients have a day room where they can go out to watch TV, and so if you have a patient that requires oxygen, then we need to provide portable oxygen so that patient can come out their room and go and watch TV out in the day room. Just giving more information about what is available. There are lots of advocacy and support groups out there, the Texas Inmate Families Association, Texas Prisoners Network Support, I just mentioned a few there, that are are support groups for families and offenders, both. And a lot of families utilize these support groups, a lot of times if they have questions and such, and they try to help the families of the offenders in particular, but you know, also for the offenders as well. But a very unique service for the geriatric offender is POPS, or the Project for Older Prisoners. And this was started by Mr. Jonathan Turley, he's an attorney. And POPS is actually the oldest legal organization dedicated to the issues of the older geriatric prisoner. And he created this program when he assisted a geriatric older prisoner in Louisiana pro bono, and then he discovered that there were lots of prisoners, older prisoners, that needed assistance. And so this program employs law students. They can either take it, utilize it as academic credit or for volunteer work, and they look at the cases of older prisoners in particular. And if these are low-risk offenders who are likely not to be recidivists, and of course if it's not a serious crime, then they try to see if they can get these offenders released, supervised release. They look for housing, and they basically prepare everything for the parole board. So it's a very nice, unique service for the older offender. And then I wanted to point out that there are volunteer groups that come on site to the prisons. A lot of them have a religious affiliation. But there are groups that come out, you know, sometimes to drop off, like at Christmas time, sometimes drop off like little presents for the patients. Usually it's like a little bag of shampoo and soap and those sorts of things at Christmas, but they also come sometimes to read the Bible and do other things. But we do have groups that come on site as well. What is a lay-in? That's a kind of hard one, huh?
Staying home for the day because you're not feeling well.
Nope, but kind of close. I'll give that to you. Hey, you get it for the effort for sure. I appreciate it. But yeah, well, you know what? I think actually there might be more than one definition that I think about it. Thinking on the outpatient side, they do ask for a lay-in. So actually you are technically correct, but this definition that I had here was an appointment, because they can get a lay-in actually to stay in their bunk, but they can also get a lay-in because they need to go on the unit to a separate area like medical. Like if they have an appointment with me, then they would get a lay-in, or they need to go see the mental health specialist or something like that. So that's what a lay-in is. Medical parole. Personally, I think very important, particularly in the older prisoner. It's also known as compassionate release in many places. In Texas, we term it MRIS when a patient asks for medical parole. which is medically recommended intensive supervision. In Texas, there are two components necessary. One is, the first is medical eligibility or referral. So a provider has to refer a patient for medical parole, or a family member can refer a patient for medical parole, patient's demented. But there has to be a referral, and most importantly, there has to be approval by the parole board. And the form that the providers fill out basically includes, not surprising, information on functional ability, information on their prognosis, life expectancy, those sorts of things. And the process may take from weeks to months. Try to do it as quickly as possible. And you want to recommend your patients as early as possible because the process takes some time. And the qualification is dependent upon many factors. If they've done it has to be a non-violent, non-sexual offense in general for them to be eligible for medical parole. And of course, the more debilitated an individual is, the more likely they are to be eligible. But I wanted to point out it is dependent on many different factors.
Excuse me.
Yes.
Is the POPS project that you mentioned similar to this compassionate release? And in Texas, who manages that? Are there
No, I'm sorry. POPS is unique to, I believe it's, is it California or Washington? It's not a Texas thing.
Right,
it's just this one person.
Their process.
Mm-hmm.
The things that they do
Uh-huh.
to get people out of prison and into the community.
Right.
It sounds similar to this compassionate release.
Compassionate release is basically based, the initiative is purely a medical reason. Where POPS, there's no medical reason behind it. They're just reviewing cases of patients, like I wasn't going to mention this, but since you asked, the case that initiated it, and don't quote me on any of this, but pretty much it was a man that was convicted. He did like a robbery, just a simple robbery. And he got like a 40-year sentence, and this was like in the 60s or long time ago. And so they picked that. That's the first case that started. It just seemed like the sentence was just not proportionate to the crime he committed. They learned out he had a low IQ. He had maybe some mental issues, and so they were able to get him released. So that's kind of how it started, and that's the cases they kind of undertake in POPS. Yeah, but to clarify, POPS is not affiliated with Texas. That's just the only, it's unique. It's the only project of it like its kind. So this slide here just demonstrates you look at how many are recommended to parole and how many actually get released, and like in 2003, you had almost 600 that were recommended, but about 100, maybe not quite 100, were released. So just to give you an idea of numbers of what is actually occurring, and the most recent one, 2010, the overall recommended was lower, which makes, I guess, the overall fraction of approval a little bit higher since the total number wasn't so high. But it's really not a tremendous amount that do get approved for medical parole.
Mm-hmm. If it's not required or criteria for compassion release that they have a terminal illness, as there's other.
Oh, absolutely. Very good question, Tony. Tony asked, is terminal illness the only criteria for compassionate release or for medical parole? And no, dementia, actually all of our patients over either 55 or 60 have to have one. So age alone is a criteria. There's many criteria for medical parole, but it is not exclusive to just a terminal illness. I mean, if a patient has a change in functional status, even that can be a criteria, and it's left up to the discretion of the provider. But we do have definitive criteria to make sure that we try to capture as many people as we can, because if they can, then we want to fill that form out. Transitioning to release, there are various types of release, medical parole being one of them, but patients just completing their time. But there is a discharge planning process, and The patients are given a 10-day supply of their medications. Like for instance, if one of my bedridden patients is going to be released, they do try to place them into nursing homes. There's a process of trying to get them into the appropriate places, seeing what services are available, whether it's Medicare, Medicaid, whatever, and getting them into those areas. I mean, in some instances we have difficulty, but most cases we are able to place our patients. And those that are, the younger patients, generally there's no issues at all. And then there is information given about community services so that when they leave, it's not like we send them out with nothing. We try to give them as much information as possible so that they'll have everything set up when they do leave. Clinical challenges. I often get asked, why do I do what I do? And it is challenging, but it's rewarding at the same time. But just to make all of you aware of some of those challenges that we face, all of us who work in the correctional setting, it is a prison first, and security is paramount. So that's always security and the safety of us and of the other patients it takes precedence. There are a lot of things we can't bring into the prison. I think about patients with like wounds where you could take pictures. We can't bring in cameras, we can't bring in tablets, we can't bring in any electric devices. So much different from what people do in the free world. But we do have limited access to the internet and able to get to materials that we need. You have to always keep in the back of your head if something, it can potentially be a weapon. So when you go into a room, you don't need to leave a paper clip behind or a pen or any materials. When you go in, you need to take everything out of the room. All transportation requires security escort. So your patient doesn't move for this appointment or for this x-ray unless security is present. So sometimes that can, delay some of the things that you may need. We do have a medication formulary, so we do have a limited amount of meds, but it's very inclusive. And not uncommon to out there, compliance is an issue everywhere, but our patients have to peel windows at 4 in the morning, so they have to get out of bed and go and get medications at 4 in the morning. So some of them, may not want to do that. So we always have the compliance factor. Or when they have to come down here to Hospital Galveston for an appointment, they might have to get on the chain bus at 2 o'clock in the morning and be at Hospital Galveston, all day for an appointment that was at 1 o'clock. So there are some challenges that are definitely unique to the prison setting. What is SEG or ADSEG? Go ahead. Yes. Okay, I'm not gonna throw that far. Okay, thanks. All righty. SEG or ADSEG is segregation, isolated or disciplinary unit, also known as ADSEG. Okay, ethical issues in prison care. Some of this I believe I have touched on, but of course there's the issue of trust and the attitudes and belief that the inmates themselves may have about prison officials and healthcare providers not working in their best interests. So just as all providers do with their patients, establishing trust and know that we're not out here to hurt them. We're not trying to harm them. It's not that we don't care. They're not just getting the experimental medicine, the experimental doctors, like where did we come from? It's the same. I mean, in all of us that work there, we really try to give the best care that we can, but there is that trust issue that is definitely ever present. On the flip side, bias on the part of the staff providing care. I mean, the comfort level of the staff, their beliefs, their, what they may have an issue with. Sometimes, I know I personally don't intentionally try to find out what the crime or offense is that they're incarcerated for, but sometimes you find out, is that going to affect your judgment, your care of the patient. And for me personally, no. I mean, this individual is a patient first, and that's how I look at it, and I want to give the best care possible. And something that we frequently encounter, especially with the older prisoner, that can make care difficult is when we don't have family support in making decisions for our patients. That can, particularly the demented patients, and that can be quite challenging when we don't have that support. And then, of course, how does society feel? You know, it's all anecdotal, of course, and it's a difficult factor to objectively assess. And, you know, I certainly can't speak objectively about it. But, you know, if you look at the literature, you know, if you read the paper, if you talk to your friends, you know, most literature suggests, you know, a lack of public sympathy or concern. Most people are indifferent to the care of the prisoner, of the older prisoner. But it's something, you know, that, you know, we can't essentially just ignore. You know, they're behind closed doors, they're locked up. It's kind of like out of sight, out of mind, don't have to think about it, don't have to worry about it. But with this rising elderly population that continues to rise, it is something that we need to think about. What are we going to do? How are we going to approach this? So where do we go from here? And this is a list I just came up with. Continued emphasis on medical parole, I think, is very important. You parole the patients that you can. Disease prevention and chronic disease management. I think about last lecture series in April and some earlier where Dr. Goodwin talked about, you know, appropriate screening in elderly patients, what's appropriate, what's not. You know, we have to be careful, but I think there needs to be a multidisciplinary approach to this and to how we provide care. How do we manage diseases in this aging population? You know, we need to do what's appropriate. One big thing which is difficult is when you do have that patient that can tell you what their wishes are, you need to listen as a provider and you need to document. If they want to do not resuscitate, then you need to do that. But a lot of times we don't have time. A lot of times our focus is on, you know, a patient with 20 problems, but you really do need to make that time to discuss and document end-of-life care and wishes. And then continued security, staff training as this today in awareness. And I just threw this in there, not really related to the older prisoner, but just to show you where Texas, this is the cost per day per prisoner, the cost to take care. And as you can see, Texas currently is $9.88, projected to be $7.75. So compared to California, for instance, $44 a day, just to kind of give you an idea of the cost. I think this is the last one. What is a Johnny? Yeah. It's a sandwich. Our meal served in a brown paper bag, usually a sandwich, usually when they're on lockdown, or sometimes it's punitive by security, but a Johnny is usually a sandwich or a sack lunch, basically. So what I really wanted to, as Meredith's talk is next, is kind of just parallel this case to the free world. Not much on this first slide here, but if you go here, you know, basically 63-year-old, he becomes incarcerated. What might have happened differently had he not been incarcerated? Incarceration itself is a stressor, so that right there could have been the first trigger. I mean, he was placed in prison. And he has some cognitive impairment on admission. He goes to the hospital and he gets very good care. He's treated for pneumonia, he's discharged to the infirmary, he gets physical therapy. Well, in the free world, in the community, he likely would have gone to a SNF maybe, which we do have SNF level beds, but just not, of course, the care is not exactly the same as the free world. And, you know, the therapy probably would have been a bit more intense. He got physical therapy at the infirmary, but he didn't get it probably to the level he would have gotten it at a nursing home. So that difference there, and then because he's in prison and he's wandering, and you know he's on a unit with many different types of guys, we had to confine him for his own protection. So you take a patient with dementia, with cognitive impairment, and you put him in a room majority of the day, every day. You know, you're going to see some physical decline, you're going to see some mental decline inevitably. And so his whole process is just accelerating. Then, you know, the weight loss continues, and, you know, there's probably some depression in there as well, along with all that. And then we're left with a patient who's lost 40 pounds, and now we're faced with placing a peg tube, and we have no family. He can't tell us because of his dementia, and we have no family to guide us in making that decision. So this just makes for a huge, I guess what I wanted to really impart was this makes a huge recipe for accelerated decline in a patient with dementia versus if he had not been incarcerated, you could imagine that the trajectory might have been quite different. So any questions, any, what do you think, what would be the next step? Mm-hmm.
Quality of life,
Mm-hmm.
no support system.
Mm-hmm.
So who decides whether to give him a peg tube or
Not right.
let the progression, natural progression of the...
Very good point. And for those off site, what she said was, who makes the decision basically on whether or not this patient gets a peg tube? You know, you look at the quality of life, you look at the natural progression of dementia, all very good, very valid points. No family support. Where do we go? And I'm faced with that. I have been, not this exact case, because this is not an exact case of the T, but we're faced with these difficult questions. Of course, you know, I go to my supervising physician. You know, a lot of times, you know, several physicians will discuss the case, but ultimately ethics and ethics committee consult is where we would go with this and talk to ethics. And from my experience, usually they'll say if you can find anyone who can give you any idea of what the patient might want, even an ex-wife, a friend, you know, if you can find anybody, that's usually the first thing that they'll say. And in this case, as I said, that there is no one, then we're left to decide. And, you know, we weigh, you know, many different things. Like one thing in this case, I would say, okay, is the patient, because we know like a peg tube is not going to prevent aspiration. We know about the, you know, a lot of times with dementia, the patients just lose the desire to eat. It is the natural progression of the disease. And so you weigh all that, and then you know, another factor to consider is the patient like really hungry? Is he always wanting to eat versus someone who's just kind of laying there, really not engaged, really not wanting to eat? And then essentially we make, with the assistance of ethics, we make the decision. A lot of times, from my experience, once again, a patient like this, you know, if he had that desire to eat, he would probably get a peg tube. With no family support, just not knowing where to go, he would probably, which I know some people may not agree with, but then he may not. I mean, it's just a case-by-case basis, basically, is how it's determined. Any other questions? Offsite? Okay. Oh, okay. Yes. I'll take any questions at this point. Mm-hmm.
We have a pretty strong telemedicine program here.
Mm-hmm.
Does that go to the prisoners?
Yes. The telemedicine, very good question. So only question was, we have a pretty solid telemedicine system here at UTMB. Is that the same one the prisoners use? And it is. But we also use telemedicine from unit to unit as well. So for instance, my facility has a mental health nurse practitioner. So she will use telemedicine at Carroll Young to see patients at other facilities. So it's used here, it's utilized here, and it's utilized throughout the system. And it's a very useful tool for us.
What about female prisoners? Same thing, everything applies? To,
Yes.
A separate facility
Mm-hmm.
that you have for the female?
Yes, Tony's question was about the female prisoners. Of course, the numbers are a lot smaller, but yes, all the same. We have the female hospice unit, which is at Carroll Young, and we have a female infirmary beds. All the same principles apply for both men and women.
Teresa,
Mm-hmm.
maybe I missed this, but when someone has medical parole, if they are outside of the correctional managed care, do they, how do they get their health care? Because I've heard that if, you have to apply for Medicaid and when you're being discharged from the prison, and then, so if you get discharged on medical parole,
Mm-hmm.
are you going to a place where you have zero care?
It depends. I mean, I've had patients who leave on medical parole that do qualify for Medicaid or Medicare.
But it takes some time to set up. So
Yes, and we don't really, and that all has to be set up. Like sometimes I discharge them home to hospice. All my orders, oxygen, that's all set up before they're allowed to be released. Yeah, that all has to be set up before they're released. Meredith's question for those off-site was, if a patient is released on medical parole, basically, questions about what services are available, Medicaid, Medicare, and how do we basically ensure those services are set up. But they're not released until everything's in place. Particularly with our medical parole patients, particularly with the ones that are very ill, they don't have long to live, 3 months, 4 months. We make sure everything's set up. We do. Yes, ma'am.
I'm sorry, I'm hoarse.
It's okay.
I have a question about being buried on prison property. Being buried.
Okay, the question is being buried on prison property, okay?
How is that determined? Is it like if you don't have any family members or you don't have financial?
Mm-hmm. The state takes care of it. You're buried. Yeah, there's a cemetery somewhere. I want to say Huntsville, but don't quote me on that. I'm not for sure. But yes, the state will bury you. If there's no one to come and claim the body, essentially, is what the question is.
I had one more, sorry.
No,
But, yeah,
lovely.
wait a few minutes.
Okay.
And this might be for our other sites. Within the GC service area, we have a lot of criminal justice programs. Lamar has one, SFA. I think we're in the Huntsville area. And I was just wondering, I don't know if you noticed, but about how much of this kind of information do you think those programs cover for health care for the prisoners, and especially geriatric prisoners, within that the curriculum? I mean, do you think there might be things that we'd be able to help kind of increase some of that content or work with them? I don't know I'm not familiar with all the criminal justice programs, and I don't know if there's anybody.
Yeah, I'm not either. I'm not either.
You know, just something that we might be able to think about. This is great content, and I'm wondering how much of this they get.
Yeah, and as far as criminal justice, I wouldn't know. But like you said, maybe someone off-site can answer that question. That would be great as far as information on the care of prisoners, particularly the older prisoners. You said.
If Jim Mant was on here at Lamar, he's a psychologist in the criminal justice program and one of our consultants for the GEC, and I know they do a lot of work on looking at older prisoners that have dementia within their criminal justice program. I'm wondering how much of like the communication issues, some of that. I'll talk.
I need to get that link that they asked about. And the other thing is, if you go to the CMC website, there is information there. Like there is a very nice a presentation that was actually done for security about the older prisoner, you know, that I actually found useful and pulled some information from, and there's other information there too. But that would, you know, that's a good question, and this information would certainly be useful, I think. I'd love to share it with whoever is willing to listen.
I just have a comment.
Mhm.
I do work at TDC as a therapist. We have outpatient clinics and we see the inpatient offenders as well.
Mm-hmm.
And it is a very challenging thing because once you get with the patient and you're doing your job, it becomes just like any other patient many times. But you
Mhm.
have to keep in mind that it's not just any other patient, about what you can talk about, like you said, the things that you can use, how you interact with them.
Mhm.
But I guess the other challenging thing is just society's concept of healthcare for the incarcerated individual, and there's so many people who are not incarcerated who have very difficult challenges with getting their own health care.
Yes.
It's just it's a huge thing.
Mm-hmm. No, absolutely. Actually, that was something I wanted to mention on the slide I had about society, and that is something I frequently hear. Well, they're getting all this expensive treatment for their cancer, and there are people out there with no health care that are not incarcerated, and that is probably one of the toughest challenges. And I mean, I totally agree with that. You know, and how do you answer that question? How do people feel about that? Because they are the only citizens actually with the right to have adequate health care. They're the only ones. They have a right to have health care. And you have people that have none. So it is a very difficult, to say the least. You know, how do people feel about that? You know, it's for every person. I'm sure it's different, but it was.
With a medical parole in our nursing home.
Mm-hmm.
It was a success story because he got better, and we were able to send him back to the community. His parole was, in that sense, it was a successful program. But of course, Dr. Brockins is a miracle worker.
Very good. Anything else? Anything?
Anything?
From the other sites? Any other comments? Thank you very much.
Thank you. Thank you. Thank you.